We are live now. So, good morning, dear delegates and respected faculty. I welcome you all to the second episode of the T1DE module. We have Dr. Sameer Aggarwal today who will be presenting uh, about do all the children have diabetes or type 1 diabetes? I request Dr. Sameer to please start sharing his screen.
Thank you, sir, for uh, arranging good academic events. Thanks to Rajiv and IAP, Dr. Jain, Dr. Bhandari. And I think they are very strict with regards to the protocols, and that's what is required in these meetings. And Rajiv has been passionate about type 1 diabetes. His main aim is to increase the education for type 1 diabetes in physicians, in pediatricians, and amongst general public also. Thanks, audience, who have taken time out of their busy Sunday morning or maybe relaxed Sunday morning to log in. So I will be talking about whether encountering children and adolescents with diabetes, is it all type 1 diabetes, or we can have some other diagnosis also, maybe secondary diabetes or type 2 diabetes or some monogenic diabetes. So I will be sharing my thoughts on it and few cases which I have encountered over a couple of years in my practice.
Okay, so while Dr. Sameer is sharing his slide, sorry.
Yes, Rajiv.
Yeah, I was just saying that while you are opening your slides.
Yeah, I have shared, I think. You can see.
Yeah, please go ahead. Please go ahead.
You were saying something?
No, I was saying that I just wanted to introduce you to the audience. I was just saying that Dr. Sameer Aggarwal uh, is a DM endocrinologist from AIMS, and he has worked as a professor of medicine at reputed PGI Rohtak, and he's a very dear friend and a very great speaker, and he's current president of our association, society for promotion of education in endocrinology and diabetes. That's diabetes, and we look forward to a very great session here. Over to you, Dr. Smith, please.
Thank you, Rajiv, for nice words. So I think this is what was the national survey from UK was showing the incidence prevalence of type 1 diabetes, and I think majority of the cases were 99% were type 1 diabetes, but you have other cases also encountered less frequently like type 2, monogenic diabetes, some syndromic diabetes, some secondary diabetes, some endocrinal disorders. But we feel that the picture is changing and we are encountering now type 2 diabetes also in children, and also with more diagnostic and genetic studies being done. I think we are picking more MODY or monogenic diabetes also these days. Uh, this was the, I think, registry of youth onset diabetes in India, where you can see type 2 diabetes picking up. Also, we have gestational MODY, secondary diabetes because of pancreatitis, secondary diabetes maybe because of drugs or some hormonal issues like Cushing's. But still, majority of the children and adolescents and the youth, they are having type 1 diabetes, as but with increased incidence of youth being overweight and obesity, I think type 2 diabetes is also picking up. So you can have various etiologies of diabetes in youth, in adolescents less than 18 years of age, starting from neonatal diabetes, type 1, type 2, monogenic, syndromic, some insulin resistance, or secondary diabetes. There can be transient neonatal diabetes. Pediatricians are more encountering these cases where there is overexpression of genes on chromosome 6q24. It is recurrent in about half of the cases, but important thing is that it can be transient also, and in some of the cases it can be treated with mild doses of maybe sulfonylureas. And of course, you can have permanent neonatal diabetes also with all these genetic defects. but majority of children and adolescents less than 18 years of age are type 1 diabetes. So what's the usual presentation? Type 1 diabetes, I think most of the audience is pediatricians. You see these typical uh, history of polyuria, polydipsia, and polyphagia. These are osmotic symptoms. Usually they are in type 1 diabetic patients. Weight loss, and many type 1 diabetic patients, they present with diabetic ketoacidosis. So if it is an adolescent or a youth who is having osmotic symptoms, weight loss, and has presented with DKA, it's most probably autoimmune type 1 diabetes. So what investigations we do? I think routine investigations we do in these children and adolescents as complete blood counts, renal function tests, liver functions. We go for imaging so that we are not missing at underlying infections like chest x-ray and ultrasound of abdomen, arterial blood tests to look for acidosis, and urine routine examination. Urine routine examination, I think, is very important in many cases of newly onset diabetes in youth. It tells you that the child is not suffering from any underlying infection. It can suggest you is there any glucosuria, but most importantly, I think presence of ketones in the urine. So any youth or adolescent who has come to us as a referral, we look for these reports, and maybe we want to look for a urine routine report at the time of diagnosis and a blood gas report at the time of diagnosis. If it's an acidosis at the time of diagnosis, mostly it is type 1 diabetes only, autoimmune diabetes. And if it is ketonuria, again, it is suggestive of that the child was having beta cell deficiency at the time of diagnosis. Antibody profile, yes, provided the patient is affordable. So practically, what I do in my clinic is that I go for GAD65 antibody. Would like to have comments from Rajiv also, but if the child is able to afford, then I usually say go for a type 1 diabetes autoimmune profile, which includes these list of antibodies: insulin antibody, GAD antibody, IA2, and zinc transporter 8. I think it's available with most of the commercial labs, costs somewhere around 10 to 12,000, but mostly it is done once in a lifetime so that we have a baseline uh, idea of what sort of diabetes in youth and adolescent I am dealing with. If the child is not able to afford, I usually say that go for a GAD antibody, but sometimes working in Rohtak, you have a child from a rural background and they are not able to go for any antibody profile, and just on the basis of clinical history, symptoms, urine routine, and the blood gas analysis, we are labeling them as type 1 diabetes. Important thing again is that the titer of these antibodies sometimes go down after a few years of diagnosis of diabetes, like zinc transporter 8 levels, they start going down somewhere around 12 months to 18 months after the diagnosis of type 1 diabetes. So it's not that if these antibodies are negative and it's not an autoimmune type 1 diabetes at all. You have to take into account at what point of time you have been measuring these antibodies. But two or more than two antibodies, if they are positive, the NICE guidelines from UK also suggest that it's a autoimmune type 1 diabetes. Another group of youth and adolescents which you can encounter in your practice can be monogenic diabetes. They may look like having type 1 diabetes since they have the same age group like 11 years, 14 years, 15 years. It is important that we are not missing at monogenic diabetes since there is a role of oral hypoglycemic agents like gliclazide or glimepiride, or many monogenic diabetes will not require any treatment at all. So consider the diagnosis of monogenic diabetes. I think Modi is one of the commonest monogenic diabetes, where you have a strong family history of diabetes, autosomal dominant transmission, persistently low insulin requirements, and lack of autoantibodies. So these are different type of monogenic diabetes. Each country has its own prevalence and most common type of monogenic diabetes. I think we have some data from southern India which suggests that the incidence of MODY was around 10% in the patients who were suspected of monogenic diabetes. But like MODY 2, some studies suggest that it's one of the common forms where you have mild fasting hyperglycemia. You do not need any treatment except any adolescent female who is pregnant. Then we need to treat sometimes in pregnancy to prevent the fetal macrosomia. But most of these MODY 2 will not need any treatment at all. MODY 1 and MODY 3, again, the incidence in some Indian studies is high as compared to the rest of the MODY variants. It can require mild doses of sulfonylurea. MODY 5 can have diabetes in association with renal and genitourinary abnormalities. In fact, some data has suggested that renal cysts, unilateral or bilateral, can precede the diabetes in these youths and adolescents. So this is the Indian data from Madras Diabetic Research Foundation. 96 patients suspected of MODY and around 9% MODY 3 and around 3.4% MODY 1. Again, the recent study from the same group, prevalence clinical features of MODY seen at a tertiary center, 10.9% incidence was there. So which patients diagnosed with type 1 diabetes should be referred for genetic testing for MODY? Continued endogenous insulin secretion 3 to 5 years after apparent diagnosis, after the diagnosis of type 1 diabetes, and no antibodies present on investigations. And type 2 diabetes, if they are not obese, overweight, no features suggestive of insulin resistance like acanthosis. So these youths can be having MODY, and they have a marked sensitivity to sulfonylureas, implying that even when you are using a glimepiride dose like 1 milligram or 2 milligram, they are going up into hypoglycemias. So that can suggest that it's not a type 2 youth. It can be a MODY variant. So can you have overweight or obese MODY also? Usually they are normal weight, but this was the today study where 4.5% of the overweight obese participants, they had monogenic diabetes. So the picture seems to be changing, but most of MODY children, adolescents and youth will not be overweight or obese. The issue is that, yes, we have discussed about the clinical scenarios like type 1 diabetes who is not having any antibodies, whose insulin requirement is very low, you are suspecting MODY, or a type 2 diabetic youth and adolescent where it's not any acanthosis, he's not overweight, you have labeled as a type 2 diabetes youth, but you are still suspicious about the diagnosis. Then how to diagnose MODY? So I think most of the organizations say that go for genetic testing. And genetic testing seems to be costly. I think not less than 20 to 25,000 for a patient to have a full profile of MODY. So can there be some biochemical parameters where you can stratify that, okay, this group of youth and children, I will go for genetic testing. So when I was preparing these slides, I encountered a couple of studies. One was from China, another from UK, but we cannot replicate the data of UK in South Asian population. But again, this was the good study published recently, identification of appropriate biochemical parameters and cut points to detect MODY in Asian Indians in a clinical setting. So these were the cutoffs like clinical parameters as well as biochemical parameters. Very good study by Dr. about BMI, HbA1c, HDL, fasting C-peptide and stimulated C-peptide. Again, for type 2 diabetes, same parameters, but fasting C-peptide and a stimulated C-peptide, they say, if these are used as parameters, they can suggest you that these are group of youth and adolescents where you can go for genetic testing. So a small number of patients, that was the limitation. But again, if we can have more and more data talking about these parameters and ROC curve generated cutoffs, maybe we can go for genetic testing in these youths and adolescents. So this was a case, first case of today's presentation. 80-year-old male, diabetes since around 2 months. Father is diabetic. Mother non-diabetic. We do not have any history regarding grandparents. So this is the usual history which I take, and most of us in our clinics. No history suggestive of any pain abdomen, osmotic symptoms, any history suggestive of DKA at the time of diagnosis, or any history suggestive of chronic drug intake. Chest CVS per abdomen was absolutely fine. There were no stigmata of insulin resistance. BMI percentile 70th seems to be fine. Fasting, blood glucose, postprandial blood glucose, both deranged. HbA1c around 6.9%. CBC, RFTs and LFTs were normal. So 8-year-old adolescent and child with diabetes around 2 months, and father is diabetic, but otherwise child is of normal weight and clinically not suggestive of type 1 diabetes. So again, I was talking about the role of urine routine. Yes, in this child, the glucose was 1 positive and ketones were negative. I feel that urine routine glucose we usually see uh, at higher blood glucose levels, but again, it's a non-specific thing. But yes, glucosuria was present in this patient. So suspicious for MODY since there were no features suggestive of osmotic symptoms or DKA, or there were no symptoms, no clinical signs of type 2 diabetes also, like acanthosis or child being obese or overweight. Except that, yes, father was diabetic, so that gives you a suspicion that maybe it's a type 2 diabetic. GAD antibodies patient was agreeing to, and that was negative. Ultrasound we did so that we are not missing at any pancreatitis. That was absolutely fine. Renal imaging was also normal. So patient went for this genetic testing, and there was a GT80 mutation suggestive of HF and HNF1 alpha gene mutation in this child, and I think it's a MODY 3 variant where you can have glucosuria also, and plus you have sometimes uh, uh, fasting and postprandial which are deranged, and that can even the levels of glucose can be mild or they can be severely deranged also. Child was put on diet control, but again fasting PP were not at targets after around 2 weeks, and 30 milligram gliclazide half tablet was started, and fasting PP touched down to normal ranges. So I think it's a proven case of a MODY in an 8-year-old male. So maybe this child will be doing fine on diet control, or maybe requiring mild doses of sulfonylurea. What about type 2 diabetes in adolescents? I think since we are having more children and adolescents being overweight and obese, this is the pattern of worldwide prevalence of child being overweight, and you can see the dark red ones are the child who are overweight. So that may be converting into pre-diabetes and diabetes. Again, going back to the same slide of YDR study, where you have around 25% children has type 2 diabetes. So risks for type 2 diabetes in children and adolescents: obesity, history of macrosomia at the time of birth, family history of type 2 diabetes, premature adrenarche in girls, and another thing which is not written on this slide, I think, is PCOS in adolescents. I think that's again one of the risk factors. So screening also is recommended for type 2 diabetes in children if they are overweight, obese with risk factors like PCOS, insulin resistance markers like acanthosis. And these are various studies which have shown what can be the clinical features of type 2 diabetes in adolescents, like acanthosis, PCOS, dyslipidemia, transaminitis, and maybe albuminuria. And this study talked about the difference between Caucasian and non-Caucasian with regards to type 2 diabetes. One thing which is consistent with most of the studies is that type 2 diabetes in children, adolescents, girls, it rarely presents before onset of puberty. So mean age 14, 12. Acanthosis is there in mostly non-Caucasian population. First and second degree relatives positive for type 2 diabetes is usually there, and majority of these adolescents and youth are overweight or obese. And they can be asymptomatic and they can present with diabetic ketoacidosis. That's a rare thing for a type 2 diabetes, but yes, they can present with diabetic ketoacidosis. And once you correct ketoacidosis, the requirement for insulin goes down over a period of time. So clinical features, family history is important to establish the suspicion for type 2 diabetes in an adolescent. And on investigations, what we will find is normal C-peptide, and you can have transaminitis, hypertension, microclinically, you can have all of these things. But I was again searching for the data that whether it is a beta cell insulin resistance or a beta cell dysfunction that is important for type 2 diabetes in youth. What about Indian data? Again, this is one of the very few studies published that among Asian Indians, beta cell dysfunction appears to be strongly associated with type 2 diabetes in youth than insulin resistance. What we understand is in adults is that by the time you diagnose type 2 diabetes, they have lost somewhere around 40 to 50% of their beta cells. But what about youth? So this is one of the few studies talking about beta cell dysfunction. So implying the fact that maybe you need therapies in type 2 diabetes in youth and adults where they are beta cell preservative and use of insulin even in type 2 diabetes. Another case, 12-year-old female, she presented to our clinic, obese, BMI percentile 97. This is how we define obesity in children, talking about percentile. So once a child is more than 95th percentile, she is obese, fasting, postprandial deranged, and HbA1c 8.5%. So 12-year-old obese child with diabetes. History, we have to talk about birth history, menstrual history, family, and nutrition. Birth history, full-term normal delivery, 3.2 kg seems to be on a higher side, normal milestones. Menstrual history is always important, that you are not missing at any underlying endocrinological diagnosis like PCOS. So in this child, she was having menarche at 10.8 years of age, seems to be slightly early. I feel the average age of menarche in Indian females should be around 11 years. And this child was having irregular menstrual cycles. Family history, mother obese, pre-diabetes and hirsutism. Most probably she is also suffering from PCOS. We do not have investigations for her, and history of gestational diabetes in mother was there, for which she was treated with insulin. Nutritional history is again important when you are encountering an adolescent with type 2 diabetes. She was consuming around 2800 calories per day. There were lack of dairy products, junk food and high carbs were there in the diet, and no exercise schedule. Mother was saying that she goes for school and tuition, so she doesn't have any time. On routine investigations, CBC, renal functions, of course, thyroid we want to do in obese children, they were normal. Transaminitis mild was there, and ultrasound abdomen was suggestive of fatty liver. C-peptide normal, and GAD antibodies were negatives because we want to be sure that we are not missing at autoimmune diabetes in a young adolescent. So this is the picture again, 12-year-old female, obese, diabetes, and you can see one sign of insulin resistance on this slide, that is acanthosis on the neck, which can be there under the axilla, on the knuckles. So that's a sign of insulin resistance. So any other investigations the house would like to have? I think importantly, we want to rule out that we are not missing at underlying Cushing's also. Sometimes they can present with same picture. And another thing I told you, this child was having irregular menstrual cycle. So I want to be sure that I am not missing at PCOS and Cushing's. Baseline cortisol, which we always do at 8 a.m. was 12 microgram per deciliter, and testosterone was 0.45. The cutoff is 0.4 nanogram per ml, so it's on higher side. So are you satisfied with cortisol, and you have ruled out because the normal range of cortisol is around 4 to 20 microgram per deciliter at 8 a.m. So we know we always want to do a dexamethasone suppression test to rule out Cushing. So we are not satisfied with this level of cortisol. So we did a ONDST in this child. It was 1.1. microgram per deciliter. So that's a normal. It should fall down to less than 1.8. So this is a child who is type 2 diabetes, obese, acanthosis, signs of insulin resistance, one antibody is negative, and also PCOS. So she is a type 2 diabetic child, and she was put on diet, lifestyle, and metformin once in a day. And after 6 weeks, the blood glucose was normal. And now the mother, the family also understands that they have to be strict with regards to diet and lifestyle. So, incidence of type 2 diabetes in youth, are we seeing any disturbing trends? So, this is the paper which is suggesting that yes, type 2 diabetes is now coming up more than type 1 diabetes in some parts of the world like Taiwan, Japan, and Hong Kong. So I think we will be looking for Indian data also in coming times. But ICMR registry of diabetes in young suggests that 25% of individuals developing diabetes under the age of 25 years had a diagnosis of type 2 diabetes. So I think we are going to encounter more and more children and youth with type 2 diabetes in our clinics in coming days to come. So we have talked about type 1 diabetes in adolescents less than 18 years. We have talked about monogenic diabetes. We have talked about type 2 diabetes. There can be diseases of the exocrine pancreas, like a 14-year male or female presenting to you with diabetes. So these are the various causes of exocrine insufficiency leading on to endocrine insufficiency, like pancreatitis, fibrocalcus, pancreatopathy, cystic fibrosis. So out of these disorders, I think fibrocalculus pancreatopathy is the one, but we rarely encounter, I think, in northern part of the area. I think Rajiv can tell us more about this, but I rarely encounter these cases. Only a couple of cases I have encountered in the practice. So fibrocalculus pancreatic diabetes, I think, is concentrated more in maybe eastern or southern part of India, where these children and adolescents, they are suffering from diabetes, they are lean, they are having in between pain abdomen, and once you do an ultrasound or an x-ray imaging of the abdomen, you find a large dense pancreatic calculi. So prevalence varies from various studies. It can be 1% of all diabetic patients at one center. I think the diagnostic criteria is occurrence in a tropical country, diabetes diagnosis by the standard WHO criteria, evidence of chronic pancreatitis like pancreatic calculi on X-ray, or at least 3 of the following like abnormal pancreatic morphology, abdominal pain, steatorrhea, abnormal pancreatic function test. And there should be absence of other causes of chronic pancreatitis like alcoholic pancreatitis, hepatobiliary disease, or hyperparathyroidism. So these are the diagnostic criteria for FCPD. So these children and adolescents, they will present with diabetes, but they will be rarely ketosis resistance because they have some preservation of beta cell functions. This was another third case of today's presentation, 18-year female, diabetes since 1 year, weight 47 kg, and I think if you go on these pink growth charts for girls, it seems to be on lower side. HbA1c was 10.9%, fasting and PP were not controlled, urine routine glucose was there, but there was no ketone urea. Venous blood gas, I imply sometimes it sometimes becomes tough to check for arterial blood gas, so we go for venous blood gas. That was fine. But there was history of pain abdomen and off and on loose motions. So once a child adolescent is coming to you with these complaints into your clinics, I think it's very important that we go for imaging, especially ultrasound, to rule out that we are not missing at pancreatitis, which was of course there, but I have the image of X-ray. There was no family history of diabetes, so implying that it's not a type 2, it's not a MODY or monogenic. There was no history suggestive of any chronic drug intake which can cause some pancreatitis, or any history suggestive of renal calculi. Investigations were normal except for glucosuria, and this was the X-ray of abdomen where you can see almost the pancreas is replaced by large ductal calculi in body, head, and tail throughout. So it's sometimes a difficult picture in adults to differentiate between alcoholic versus the fibrocalculous pancreatitis. But usually in this age group where the child was not alcoholic, it seems to be a FCPD. Uh, so the child was put on insulin basal bolus and is doing fine after around couple of months. Another rare encountered diagnosis of cystic fibrosis and diabetes, I think never encountered, but this is what is written in the literature, that if the lung functions are deteriorating in a cystic fibrotic patient, then you must measure glucose. And if you are suspecting diabetes, after the 10 years of cystic fibrosis, I think regular sugar glucose monitoring should be done in cystic fibrotic children. And once the glucose is controlled with insulin, that improves the lung functions also in these children and adolescents. So many syndromes you can encounter in children and adolescents with diabetes. These are full lot of syndromes, but I think we see sometimes Turner and Klinefelters, and rarely we see diabetes in them. Uh, these are theoretically mentioned syndromes where they have their own peculiar pictures, like developmental delay, early onset diabetes, bony dysplasias. So you have to, I think, remember. So symptoms, Prader-Willi, Bardet-Biedl, and Elstrom. I would like to discuss one another case which I encountered in the practice. This child, parents' concern was about micropenis. He was 12-year-old. BMI was on higher side. You can see truncal obesity also in this child. Micropenis, I think we usually define that once the stretched phallic length is less than 2.5 centimeter at the time of birth, it's a micropenis. And we have these normative charts with us, so we compare. But this child was definitely having micropenis. But the investigations were also suggestive of hyperglycemia. Fasting and postprandial all were deranged. When we looked at the clinical examination, you see clear-cut polydactyly in this child. So we searched the literature and tried to find out, is there any syndrome in this child? We did a fundus examination. It was reported as normal by one of the ophthalmologists, but I again called him and told him that please do a dilated fundusgraphy. And I think you can all see this picture on the slide. It's one of the very rare case reports from India. I do not think we have more than a couple of these. This is a bony spicule suggestive of retinitis pigmentosa. So this child is fitting into most of the diagnostic criteria of a syndromic obesity, which is called as Bardet-Biedl syndrome. So it is involving polydactyly. It's a micropenis, obesity, plus retinitis pigmentosa. We do not need any further testing in this child, and the diagnosis is clinically established. So these are all syndromic diabetes. Sometimes you can encounter, rarely in your practice, in adolescents less than 18 years of age. Mitochondrial diabetes, where you have this maternal inheritance, some ear issues, retinal dystrophies, and hyperglycemia can be mild and progressive in these mitochondrial diabetes. Defects in insulin signaling, again these syndromic, where abnormal phases, growth retardation, acanthosis, lipodystrophies can be there in leprogenism or Rebson-Mendenhall syndromes. Type B insulin resistance is what we call when we have insulin receptor antibodies against this, and you have high level of insulin resistance and diabetes. But this is important: drug-induced diabetes, steroids, post-transplant, protease inhibitors, and now I think more and more use of immune checkpoint inhibitors, and we have going to have a talk in SpeedCon also, that can cause beta cell deficiency. Endocrine causes of diabetes, I think these are important, and we all have seen these cases of acromegaly with diabetes, pheochromocytoma diabetes, hyperthyroidism with mild hyperglycemia, which is taken care once to put the child on antithyroid drugs, Cushing's presenting with so many endocrine features. So case 5, I think this is one of the last cases for today's presentation, where 18-year-old diabetes since 2 months. You see at the faces, and you can see at the front picture of this 18-year adolescent. So Rajiv can make the diagnosis clear cut, and most of you can make the diagnosis clear cut. You have abdominal stria. So what's these abdominal stria are suggestive of? These abdominal stria are suggestive of corticosteroid excess, Cushing's. It can be a Cushing's disease. So these are not normal stria, these are pinkish, widened, dehiscent stria, significant stria, and you have these moon faces also. So weight was 74 kg. I didn't have the BMI at the moment. Blood pressure was high according to age of the child. Pubertal examination, which is must in all endocrinological diagnosis, was normal at 12 ml. Investigations: blood glucose fasting PP 145 to 21 milligram per deciliter, urine routine normal. Transaminitis was there. Anything in history would you like to have when you have this adolescent? Features of abdominal stria, overweight, moon faces. I think it's very important to have the history of chronic drug intake. On leading question, the child was saying he came from a village that he was being treated for some dermatitis from a local RMP at his village, and we did a serum cortisol at 8 a.m. It was 0.6 microgram per deciliter. The normal range of cortisol is 4 to 20 microgram per deciliter. So the audience must be thinking that I am talking about Cushing's, I am talking about cortisol excess, but now the cortisol is low. So there is a discrepancy between what the patient adolescent is showing and what the investigations are showing. So this is a peculiar picture which happens once these children, adolescents, they are taking exogenous steroids, and you have all of these children and adolescents coming up into your clinics. The prescriptions, I asked the child to bring up a prescription which was only I could read was Medrol. Sometimes this child was taking 4 milligram OD or BD for around 10 months. So it's a exogenous Cushing's, diabetes. So what we require immediately is to do an endocrinological investigation and ACTH stimulation so that we are not missing at adrenal insufficiency. So these are various cases I have discussed about. So these are type 1, type 2, monogenic, and FCPD. I think you can look for the differential at age of onset, family history of diabetes, overweight, markers of insulin resistance, C-peptide levels, and insulin antibodies, which differ in all of these diagnoses. So how do I approach a child with diabetes in my clinic? I take a birth history, birth weight, antenatal history also I think is important, which is not written on this slide. What was the mother, whether the mother was having any gestational diabetes, what was the weight gain for the mother, what was the birth weight for the child, and what were the milestones. The age of diagnosis of diabetes, whether there were osmotic symptoms, whether any history suggestive of diabetic ketoacidosis is of paramount importance. Family history of diabetes, any history suggestive of pain abdomen, chronic drug intake like we saw in our last case, any history suggestive of hearing loss. Some syndromes which I discussed in a quick presentation for a couple of slides was we are not missing at mitochondrial diabetes, Rogers syndrome, Wolfram's. These are rare syndromes which can be associated with diabetes in children and with hearing loss. Examination, pubertal Tanner staging is important. Always check for BMI percentile in a child and adolescent. That will suggest you whether the child is having obesity or the child is overweight. Blood pressure measurement is very important. More than 120/80, I think in a child more than 12 to 13 year in an adolescent is not good. And of course, it's more than 90th percentile according to the age cutoffs. Short stature in a child with diabetes again can be associated with some syndromes like Elstrom, Turner's, Mela's, Bardet-Biedl. I forget all this list, but I am remembering since last night only. So these can be the causes of some short stature and diabetes. Of course, you are not missing at Cushing's where they can have cortisol excess with short stature. Acanthosis and hirsutism, especially if you are ruling out at type 2 diabetes in a child and adolescent, that can help you in making a diagnosis. Again, these insulin resistance syndrome type A, these various lipoatrophic syndromes, again this leprogenism, rare syndromes can also be associated with acanthosis, but practically type 2 children and adolescents will have acanthosis, and it's a marker of insulin resistance. Hirsutism can suggest you that yes, it is a polycystic ovarian also underlying. Fundus examination is important, yes, to rule out any chronic diabetic changes. Usually for type 1 diabetic, it doesn't develop after the 5 years onset of type 1 diabetes. For type 2, yes, you can have retinopathic changes early on. But again, to lay the importance of syndromic diabetes, like I showed you in my fourth case, where Bardet Biedl syndrome was showing features of retinitis pigmentosa. Another Kearns-Sayre syndrome can have changes of retinitis pigmentosa in a syndromic diabetes in an adolescent with diabetes. So investigations, routine investigations has to be done like CBC, RFTs and LFTs, blood gas analysis. C-peptide will tell you about the beta cell functions, but important thing is at the time of glucotoxicity, C-peptides can be falsely low. So it's not a bad idea to measure C-peptide once the blood glucose levels are controlled. Autoantibodies, like I discussed you, IA, IA2, GAD antibodies and zinc transporter can help you. Chest X-ray PA is a routine one which we do so that we are not missing at any underlying infection. Ultrasound pancreas and kidney is important to not to miss out at pancreatitis, FCPD. And if you are seeing a renal cyst in a child with diabetes and you are not suspecting type 1 or type 2, then I think workup for MODY should be done, especially MODY5, which can be associated with unilateral or bilateral renal cyst with diabetes. So this is the flowchart. Diabetes in the young, talk about family history. If it is positive, then maybe you are dealing with type 2 diabetes or MODY or monogenic diabetes. If family history is negative, then we have to check for ketones, autoantibodies, and we do not want to miss out at type 1 diabetes. So this is the general flowchart. To summarize, the correct diagnosis of diabetes is important because it is helping us in guiding therapy and improving the profile for the child. There is increased prevalence of now type 2 diabetes in children and adolescents. Low insulin requirements outside the honeymoon period, no ketonuria or DKA at the time of diagnosis, strong family history of diabetes, some extra pancreatic manifestations like hearing loss, renal abnormalities should prompt us in considering of other type of diabetes. So thank you all for your patient hearing, and I welcome you all on behalf of SPEED to our annual conference.
Yeah, I think
डॉक्टर समीर, आपका कोई ब्लूटूथ कनेक्शन गड़बड़ है.
I'll see. My phone was near to my computer. That was the only thing. But let me see. Is it okay now?
Yeah, it's better. It's better.
Okay. So I think that was a great talk covering on all aspects of diabetes in children and adolescents. For all the audience, please put up your question answers in Q&A session. We'll take it up from there. And while the questions are coming up, a few things that I just want to clarify or ask from Dr. Sameer is, so Dr. Sameer, what about LADA in children and adolescents? Because I think the major, after the initial diagnosis and everything, so the major confusion also rises in a subset of people in which we believe that they may have extended honeymoon period if they are type 1 diabetes, or they may also have LADA. So how do you what's the data and what's your take on that?
So I think we want like if it's a middle age group person, 30-35 years, who is showing a progressive decreased response to oral hypoglycemic agents, and we need insulin requirement. I think these are the group of patients where we are working up. It's an autoimmune diabetes that begins in adulthood and will not need the insulin for glycemic control for initial few months after the diagnosis, and then it will be needing insulin. So that's my usual impression for LADA.
So another thing is that I don't know what's happening with my mic and everything. Let me just give me a second. So is it whenever this type 2 diabetes starts in a youth, I have this impression that in any case, beta cell secretory capacity in them is lower as compared to when same type 2 diabetes starts in adulthood. It's what's
Mhm.
your take on that?
So I feel that LADA is usually starting after the 25 years of age.
No,
So
even apart from LADA, I'm just saying about type 2 diabetes. So like I have these couple of children who were diagnosed around 15, 16, 17 years of age, and
okay,
they maintained their C peptide around 1.1, 1, and
okay,
then few of them kind of did well on OHAs, and then they maintained it for kind of 3, 4, 5 years, and then few of them are still on OHAs, and then few of them we've been shifting them to insulin it required.
okay. So I think you
So
can have a type 2 diabetes in this 15-16 age group, or you can have a MODY also in this age group. So we need to, I think, work up for both of these things, because 15-16 year age group adolescent who has a normal C peptide and doing good with mild oral hypoglycemic doses. So again, the clinical picture, as we have discussed in the presentation, will suggest you that whether we should go for genetic testing or we treat it as a type 2 diabetes. But rarely to have a 15-16 year adolescent with normal C peptide and to be having type 1 diabetes. Most of them will not be doing good on oral hypoglycemic agents, except for a type 1 diabetes going into honeymoon phase for a couple of months.
all right. Yeah, so another thing from your presentation is that you said that in type 1 diabetes, continued insulin secretion 3 to 5 years after diagnosis, we should think of doing a genetic testing.
Yes.
So, so how do you assess whether there is a continued endogenous insulin secretion 3 to 5 years after diagnosis while somebody is already on insulin?
So very appropriately asked question. I think a child, adolescent, few years after the diagnosis of diabetes, requiring low doses of insulin or going into hypoglycemias on insulin frequently, or doing well on a twice daily dose of insulin, and the antibody profile is negative, I think that's the group of patients I would be suspicious that I should go for MODY testing in these children and adolescents. So like a type 1 diabetic, 18 year, 16 year on less than 10 to 12 units per day of insulin doing well. So that's a low requirement for that age group.
All right. Yeah, yeah. I think I would agree there because most of the time, type 1 diabetes people, as we would learn in the next session, I think would require zero point 0.8 to 1 units per kg per day of insulin. If you're requiring up to 50%, 60% of these requirements, even 3, 4, 5 years down the line. So then that means that some amount of endogenous insulin secretion is still there, which is supporting your exogenous intake of insulin that we are doing. Another catch-22 situation generally is like you said that C-peptide can be lower at diagnosis, and we can measure C-peptide at a later date when your glycemic control is good. But won't C-peptide be lower even when somebody is on exogenous insulin therapy? Would that be correct reflection of endogenous C-peptide?
Yes, you are right. That exogenous insulin will always will all cause low C peptide. But again, if you are having a normal C peptide, child on insulin, at least it is giving you information that beta cell is preserved. So I think that's my take, that a normal C-peptide at that moment will help you in giving the information.
Absolutely. Absolutely. Yeah. Yeah. So let me take a few questions that we have. So somebody is asking, I think in total IgA is the only comment in Q&A session. I think that's in context with anti-TTG antibodies that you must have told. So do we need to do total IgA every time that we do an anti-TTG and IgA antibodies in people?
I think it's sometimes we have to like stratify. Again, if I'm not doing a total IgA in all my patients. Ideally, yes, if you are ruling out celiac disease in a type 1 diabetic adolescent, you must do it on annual basis. But if I find a child is anemic, type 1 diabetes, so I go for IgA TTG. But if I'm suspecting strongly for celiac and IgA TTG is coming fine, then I go for IgA total also.
Correct. Right. How to pick up DID mode? Polyuria is misleading.
So again, I think you will require a hearing examination. You will require fundus examination. So if it's following into that uh, criteria, then you can have a dead mode syndrome established. I think optic atrophy is there in most of these children. So yes, polyuria and one of the syndromes can be misleading, but uh, usually the optic atrophy presents in the first decade,
Yes. Yeah,
and
yeah. I think
later features they present in the second or third decade. So that's the early one to catch up.
right. Yeah, I remember a family that I worked up while working at doing my DM at Ames. So we had these two sisters who had this Didmore syndrome, and both of them presented with falling vision in their like 9 years or 12, around 12 years of age. And then they already had some bladder dysfunction because of continued polyuria. So I think that's there. Okay, so next question is smaller gap between fasting and PP blood sugar. Does it imply anything?
I think if it's a absent in the insulin first phase and second phase response, yes, you can have. But sometimes it usually happens with the type 2 diabetes or a pre-diabetic adults we have seen. You can have opposite also, that postprandial going down also. But yeah, but again, it's if I again I feel Rajiv like going through a DMYY at this moment. So like one of the MODY variants, I forget third or fourth, you have a normal fasting and a high PPG. So discrepancy is there in that also. So so this is what I understand between these fasting and PP gaps.
Yeah, I think I agree there. Fasting and PP uh, values kind of does not really kind of come close together in type 1 diabetes. This is a situation that we see in context of type 2 diabetes, and that's largely because your fasting is higher, because your fasting blood glucose is a reflection of your hepatic
Glucose out. Yeah,
gluconeogenesis
correct. Yeah.
in the night. So that brings your fasting up. So generally, if your fasting is high, but if your PP is lower, then that is more associated with pre-diabetic or type 2 diabetes than as compared to type 1 diabetes. Okay. Then another question is, sir, when family history positive is family history positive, cannot type 2 diabetes be suspected?
When family history is positive for diabetes, I think you must suspect type 2 diabetes. For MODY monogenic diabetes, you again have a strong family history that happens across 3 generations or maybe more than that, and that usually happens across either paternal side or maternal side. This is the typical family history which is there. For type 2 diabetes, you will many a times you have a family history of diabetes in both parents.
Yeah, but I think we also need to see this point in light of diabetes, type 2 diabetes pandemic that in general we are dealing with. Now you would hardly have any families which do not have a family history of diabetes. Like somebody or the other in every family would have type 2 diabetes. So that should not lead to over reliance on a family history. If you're suspecting type 2, then stronger family history of type 2 diabetes can strengthen your belief. But per se, it's not going to be very strong point in favor of like making one diagnosis versus another. That's what my take is. Okay. Sir, your comments on lean type 2 diabetes in adolescence.
So I think again we have to go to what is the data which is showing in India, Caucasian versus this. There has been some data from India way back in 60s, 70s where 20 to 30% they were lean, uh, uh, and markers of destruction of beta cells are absent in majority of these patients. So but type 2 diabetes lean we are rarely encountering. uh, High prevalence, some studies have shown a higher prevalence, but again I don't think we have a consistent picture on this lean type 2 diabetes. But again, important thing is that if you have a lean type 2 diabetes, you have to be very sure that you are not missing at autoimmune diabetes, or you are not missing at that type 1b idiopathic type 1 diabetes. And you have a one of the studies which was there that uh, failure to oral hypoglycemic agents occur frequently in these lean type 2 diabetes.
Right? Yeah. Yeah. I think I agree there. Hmm. Do we need to do ABG or VBG may suffice, as SPAT guidelines definitely are based on VBG? So I think we should park this question for our session on DKA. But yeah, I think VBG can easily be used for diagnosis as far as classification of DKA is concerned. But let's take this question in that session only. How important is diet in various forms of diabetes, especially in less than 10 years? I think that again is a session in itself, and we do have a session on that. But I think after insulin, we have a session on diet. So we and Dr. Ashima is going to discuss diet in type 1 diabetes and other this thing. So I think we'll take it up there. Sir, any role of oral hypoglycemics in type 1 diabetes?
At the moment, I think we oral hypoglycemics are not recommended in type 1 diabetes, but some type 1 diabetes are obese or overweight. There you can use metformin, but I think short of that, no role of oral hypoglycemic agents in type 1 diabetes.
Okay. What about SGLT2 inhibitors?
I again feel that the SGLT2 inhibitors have been used out of the indication, and I have also used in few type 1 diabetic patients where again they were overweight and obese. But I feel is that they work for a couple of months and then they lose their effect. So because the mechanism of type 1 diabetes is such that we don't have much role at the moment, and they are not recommended by any guidelines for use in type 1 diabetic patients.
Okay, so basal bolus regime is better or mixed for type 1, considering school timings.
Always use basal bolus in type 1 diabetic patients. Mixed is not going to work in these children. So you have to adjust the doses of insulin as per the school schedule. So most of the children will be going to school, they will be like 6 years, 7 year, 8 years, where they can inject the injection themselves. So you can ask the child to inject the lunch dose in the school itself. So that's my take. But mixed-art, okay, if you want to use a mixed-art, then again, you will have to give a pre-lunch dose in the school of a rapid-acting analog.
No, yeah, I absolutely agree. I think mixed-ard is not standard of therapy. Basal bolus is standard of therapy for type 1 diabetes treatment, given any consideration. So basal bolus is what we need to do. Sometimes in Indian context, it becomes difficult to manage uh, values in the post-lunch time after children come from their schools. But again, we have a entirely complete one session dealing with all those things coming up in the session. So I think we're going to discuss all these things in detail at that time. Uh, how frequently can we do fundoscopy?
Once you diagnose a type 2 diabetes in an adolescent, you must do a fundoscopy at the time of first visit and then maybe once in a year. For type 1 diabetes, they will not require fundus because of retinopathy changes take time to develop. So 5 years onset, after the onset of type 1 diabetes, we need periodic retinopathy screening. So that's usually which is advised for type 1 and type 2.
Okay, yeah, I think that was uh, that's the all questions that we have for today's session. Uh, Dr. Gupta, Dr. Jain, I think over to you.
Uh, thank you, Dr. Ajay.
Doc,
Dr. Vipul, are you there?
Yeah, I'm there. Please take over.
Ah, thank you, Dr. Sameer, for such a wonderful presentation and discussion. And thank you, Dr. Rajiv, uh, for moderating this session. And we thank all the delegates for joining this. So, Dr. Vipul, can we close the session now?